كتير منكم ربما بيعرف الدكتور محمد أبوالغار السياسي، لكن ما يعرفش الدكتور محمد أبوالغار العالم يعني. لكن أنا واثق إن كتير منكم عمل سيرش وعارف مين هو الدكتور محمد أبوالغار. اتكلم أنا كنت في بداية السنوات في الجامعة، وكان وقتها اسم الدكتور أبوالغار كما هو الآن علم بصفته أحد أهم أساتذة أمراض النساء والتوليد ليس في منطقة الشرق الأوسط فحسب ولكن في العالم، وكان هو رائد الحقيقة حقن المجهري وأطفال الأنابيب في مصر. في وقت كان هذا الموضوع موضوع صعب فيه جدا، وأدى فيه هو وزملائه الحقيقة أداء كبير أعتقد إنه أفاد بالإنسانية والشعب المصري والانتقاء إفادة كبيرة. اللي ما تعرفوش كمان عن الدكتور محمد أبوالغار إن الدكتور محمد من أول لحظة في مايو 2011 كان عضو مجلس استشاري أعلى لمدينة زويل، ثم عضو مجلس الأمناء، وهو الآن عضو مجلس إدارة، لأنه المجلس الاستشاري الأعلى مكون من 30 شخصية، منهم 15 من خارج مصر زي ما حضراتكم عارفين، منهم 6 حائزين على الموجب، ثم بينبثق منه مجلس إدارة مصغر برئاسة الدكتور أحمد زويل بيدير المشروع. الحقيقة أن الدكتور محمد أبوالغار هو أحد أعضاء مجلس الإدارة، وهذا المجلس الصغير بيضم الدكتور مجدي يعقوب والسيدة فايزة والنجا والدكتور فاروق وردة ومجموعة من علمائنا الأجلاء. المجلس الاستشاري الأعلى بدون طبعا تعرفين بقى الدكتور فاروق الباز ومجموعة كبيرة من علمائنا اللي أثروا الحياة العلمية. أنا بس أحكي لكم في عجالة سريعة في دقيقة قبل ما نستمتع بمحاضرة الدكتور محمد أبوالغار المواقف الداعمة للدكتور أبوالغار للمشروع. الحقيقة إنه في الوقت العصيب اللي كان المدينة والمشروع والبلد كلها بتمر الحقيقة بحالة سيئة للغاية من السيولة من التجاذبات، كان بيقف الدكتور أبوالغار موقف الحقيقة الصامد والداعم والإصرار على محاربة الفساد واستكمال المشروع، لأنه هو مؤمن أنه هذا المشروع تأخر 10 سنوات وأنه ما فيش وسيلة لنهضة علمية في مصر بدون مشروع مصر القومي. في صيف 2013 كنا بنستعد لاستقبال أول دفعة، والحقيقة الفترة اللي شهدت الهجمة الشرسة من المافيا الفساد في مصر، مجموعة من رجال الأعمال، مجموعة من تجار الأراضي، ناس مما يعني يعملون ضد مقدرات هذا البلد، وإزاي تقضي على بلد إنك ألا تعطيها فرصة للنهضة العلمية. الحقيقة الدكتور أبوالغار كنا كل ما نقع في مشكلة كان حد الدكتور زويل وقتها في المستشفى بيجري العملية بتاعته بعد يعني قبل أن يتم الله المولى سبحانه وتعالى عليه الشفاء الكامل. فكنت دايما انا او مدام راجع متصل بالدكتور محمد أبوالغار، فالاقيه في نيويورك في واشنطن، قعد فتره طويله في امريكا. كانت عندنا مشكله مع الدوله وقتها الحقيقه يعني، فكان يقفل معايا ويتصل على طول بالدكتور حازم الدولة رئيس الوزراء وقتها، فيقوم يدينا جزء من الدعم. كان عندنا وزير تعليم عالي بقى الله يسامحه، كان تصريحاته كتير وكان بيغلط وسبب لنا شويه مشاكل كده، انما الحقيقه وقفت الدكتور أبوالغار واصراره لدرجه انه انا يعني حضرت لقاء ليه مره او تليفون مع الدكتور زويل قال انه هو باسمه هيتقدم ببلاغ للنائب العام ضد اهدار المال العام وضد المتاجرين باقوات الشعوب، المتاجرين بهذه الارض اللي بنقف عليها. يعني دي امور بس الشيء اذكر لانه لازم يعني نعطي للرجل حقه يعني من اول لحظه الحقيقه، وهو كتف بكتف مع الدكتور احمد زويل ومع علمائنا الاجلاء ايمانا بهذا المشروع وايمانا بانه هذا البلد لن ينهض ولن يتقدم بدون بحث علمي وتعليم. علشان كده الحقيقه الدكتور احمد زويل كان حريص جدا على انه الدكتور أبوالغار يلتقي بابنائه في مدينه زويل للعلوم والتكنولوجيا، وهو حزين جدا انه ما كانش في طليعه ويعني في مقدمه مستقبليه النهارده مع الدكتور صلاح حبيه والدكتور اشرف والدكتور طارق كل اساتذتنا والدكتوره نجوى ومدام راجيه. فالحقيقه اتصل بيا من يومين يعني الساعه 3 ظهرا، فانا بقلق الساعه 3 ظهر ده يعني الساعه 5 الصبح في كاليفورنيا، على طول اقول فيه يعني دكتور صاحي بدري او ما نمشي. فالحقيقه يعني في 5 دقائق كان قبل ما يدخل او قبل ما يبدا يومه حريص انه يمليني رساله اتلوها باسمه ترحيبا وتقديرا للدكتور محمد أبوالغار. أنا كتبتها والله الحقيقة، وأحب ألقيها على مسامع الدكتور محمد الحقيقة. الأخ والصديق الحبيب الدكتور محمد أبوالغار، يطيب لي أن أرحب بكم اليوم داخل مقر مدينة زويل للعلوم والتكنولوجيا، مشروع مصر القومي الذي طالما حلمنا بإنجازه لإحداث نهضة علمية في بلدنا الحبيب. وكنت دوما حاضرا ومشاركا منذ اللحظة الأولى كعضو مجلس أمناء مؤسس وعضو مجلس استشاري أعلى، ومؤخرا عضو مجلس إدارة مسؤول معنا عن دعم وإدارة هذا المشروع الكبير. لقد كنت أتمنى أن أكون في استقبالك بنفس اليوم وتقديمك لأبناء الطلاب الذين ستجدهم نابهين، وهم بحق من خيرة شباب مصر، وننتظر منهم الكثير، وستسعد أيضا بالحوار معهم. وما منعني من استقبالك إلا ظروف العمل والجدول المزدحم في كاليفورنيا. ولكنني على ثقة ويقين أن الزملاء بالمدينة بقيادة الأستاذ الدكتور صلاح عبية سوف يكونون على العهد بهم في حسن استقبال علمائنا الكبار، وأنت واحد من علماء مصر المخلصين وشريك في بناء هذا الصرح، ومواقفكم الداعمة خير شاهد على ما قدمتموه وتقدموه. أتمنى لكم قضاء وقت ممتع بين جنبات المدينة وطلابها وباحثيها، وأتطلع إلى لقاء قريب يجمعنا بالقاهرة بإذن الله. وفقنا الله جميعا لخدمة الوطن. أحمد زويل. أنا مرة ثانية برحب باسمي وباسم مدينة زويل بعلمنا الكبير أستاذنا الأستاذ الدكتور محمد أبوالغار، وأدعوه الآن وأترك لكم الفرصة للاستمتاع بمحاضرته والنقاش المفتوح معه، فليتفضل.
وجودي في مدينة زويل، وبشكر دكتور صلاح عبية الفايس تشير، وبشكر الدكتور بدوي الدين اوف ستودنتس، وبشكر كل الستاف العظيم اللي موجود، والاستاذه راجيه الحقيقه اللي هي بتساعدنا في كل حاجه بكفاءه منقطعه النظير. انا زي ما انا متعود ان انا بتكلم بالانجليزي في المحاضرات، يعني في الطب، وانا سالت المحاضره فعرفت ان المفروض الميديم شود بي انجلش يعني. فانا تقديري وشكري للدكتور زويل هيكون عن طريق التليفون له، انه هكلمه بعد ما اطلع من هنا، هكلمه في التليفون واشكره على الكلمه الرقيقه اللي الدكتور شريف قراها. Today I'm going to talk about advances in reproductive medicine. I'm sure this is not very close to your subjects in general, but it is part of the science and advancing science and technology. Just simple things, I'm sure you have studied all this before, that this is the uterus, and these are the ovaries, and these are the tubes, and under normal conditions the ovary is producing the eggs or oocytes, which passes through the tube, and they are fertilized by the sperms in the tubes. The sperms are deposited in the vagina, they ascend upwards and they pass into the tube. Usually they meet in the lateral third of the tube where fertilization occurs. During this journey, as you will see now, this early zygote is going to divide gradually. And as you see here, if this is the ovary, actually the end of the tube have this fembria, which is lots of small projections, and they are active and motile, and they move towards the ovary in front of the egg. So before this egg is going to rupture, they are very close. So once this capsule here ruptures and the egg is picked up by the end of the fallopian tube, and the journey starts in the tube, here they are going to meet with the sperm where fertilization occurs, and this is divided into 2 cells, as you see, 4 cells, and then large number of cells, and finally what is called the blastocyst, which is the early embryo divided into 2 parts of cells, one part which will form the future baby, and one part which is form the trophoplast, which will form the placenta or will be attached to the wall of the uterus, and protrude inside to fix the baby into the uterus. And in the fallopian tube, as you see, many sperms are going to reach the ovum, and only one of the sperms usually is going to penetrate the egg and enter the egg to cause fertilization. And this is the sperm which succeeded in fertilizing the oocyte. And here are the sequence of events and the number of days passing into the uterus, the day 2, 3, 4, 5, until usually around 8 or 9 days, then the blastocyst is attached to the uterus and become part of the uterus. The embryo become a part of the uterus. And these are the different stages which we have mentioned: 1, 2, 4 cells, a large number of cells, and then this is a blastocyst which is divided into 2 parts. This is a part which will form the baby, and these cells are going to attach to the uterus and form the placenta. Why would a woman won't be able to become pregnant? What are the possible problems where certain women cannot have a baby? The problems are many. First of all, the problems could be in the ovary. This ovary is either not present at all genetically, or destroyed by surgery, or by X-ray, or by chemotherapy, or by irradiation. For any reason, this ovary is not functioning, or the ovary is good, there are a number of eggs inside, but for some hormonal disturbance they cannot come out of this ovary. And of course this is something which is treatable. Then the second problem could be in this fallopian tube, that if this tube is blocked, is closed, is inflamed, then this egg cannot enter into the tube. So it will not be fertilized, and the woman will be infertile. She will not be able to become pregnant. Sometimes the tube is not blocked but not functioning, because the tube is undergoing continuous peristalsis, or small contractions, which pushes the embryo into the tube until it reaches finally the uterus. And maybe because of some inflammation, this tube cannot undergo the normal contractions, so the embryo will not move to the uterus and pregnancy will not occur. And maybe the cause of infertility is in the uterus. The uterus may be absent completely, or the uterus may be destroyed also by a disease, or by X-ray, or removed because of the presence of a tumor, or anything. So the uterus may not be functioning or working. This is one reason again for the absence of fertility. And finally, the cause may be the male, because there are no sperms deposited in the vagina, and this could be many problems in the male could lead to this. There are no sperms, so pregnancy will not occur, although the woman is normal and has no problem. This is one damaged tube example, very common problem if infection occur in the genital tract. The tube is blocked, and as there are some glands here, they produce secretions. The tube will be distended with this fluid, and this will be shown in the X-ray or the ultrasound examination. How are we going to treat this condition? The woman with blocked tubes. For ages, surgery has been tried and it failed, completely failed. Then microsurgery was used in the 70s, where special techniques using very fine instruments trying to open this tube. Again, results were very, very, very bad and very poor, and there are very famous cases in history where women could not become, famous women could not become pregnant because of this tube disturbance, and this changes the history sometimes. Like the Shah Iran, his wife, first very, very famous wife, had a tubal problem, so he had to marry another wife. Sophia Loren had a tubal problem. She had 5 surgeries on the tubes and it didn't work, and she could not become pregnant. The second line of treatment, which I'm going to talk about it a little now, is in vitro fertilization, which is a part. If the ovary is a problem and there are eggs inside this ovary, this could be due to different hormonal disturbances, and all these conditions are correctable by giving substitute of hormone or certain drug to change so the eggs can come out finally. But if the ovary is not present or there are no eggs in the ovary, so far there is no treatment for this condition at all till this moment all over the world. If the woman wants to become pregnant from her own gametes, because this condition is treated in many parts of the world by egg donation. The woman will have eggs from a relative or a cousin, or sometimes she can buy eggs from somewhere. This is not allowed in Egypt. It is not allowed at all, and nobody is doing this. But this is the only available treatment for this major problem in the ovary. The male may be the cause because there are no sperms at all, or there is a very small number of sperms, and a number of sperms cannot reach all this journey to reach the tube and to fertilize the egg, so the woman cannot become pregnant. And if until in vitro fertilization was developed, there was no treatment for male factor. Any man with a major problem, it was a totally hopeless situation. There are lots of surgeries, lots of drugs, but they are all completely, it was hopeless. Now I shall demonstrate 3 lines of modern types of treatment for this problem. The first is in vitro fertilization. You all know that fertilization in the human occurs in vivo, occurs inside the body of the uterus. The sperm passes upwards to the tube, and the egg comes from the ovary, and the eating and fertilization and everything occurs inside the human body. In vitro fertilization means I take the sperm and I take the egg and I fertilize them outside the body, outside the woman completely. I do the fertilization in the laboratory. The procedure of in vitro fertilization, I'm going to talk a bit about the history of this procedure afterwards when it comes to certain personnel. When it started doing in vitro fertilization, there were many problems. The first problem, how shall I take the egg from the ovary? If I take the egg 1 day earlier, it is not mature, it will not be fertilized, because there is a certain moment where the egg should be mature. how shall I take it? From the ovary which is inside the abdomen of the woman. Shall I open the abdomen to take the egg by doing a major surgery to the patient? It was impossible. So trials were only done on animals for a long period, until something called laparoscopy or endoscopy was developed, in which a tube with a light connected could be introduced inside the abdomen through the umbilicus, this area, with a good light. Then you could see everything in the abdomen with a very, very small opening in the abdominal wall. And you can introduce two of these, one you see and one you can take sample, you can do surgery, you can do things. So the first trials was by taking this egg, using this endoscopy procedure, which was invented actually in the 50s, but was in practice in the 70s. So in the early 70s, the first trials of taking the egg using this endoscopy. So the first trials, you take the egg and it may be mature, not mature, and many times you could not fertilize this egg. So they spent many, many years until they will be able to succeed. Later on, we found that one egg is not enough, because if I can get 10 eggs or 15 eggs, I shall increase my chances of having a fertilization. So I give the woman certain drugs. These drugs will stimulate the ovary to produce many eggs, so I can have 5, 10, 15, etc. And the ovary will have 15 follicles, and I can aspirate all, I can take all this via the laparoscope. Then these eggs, which is taken, is put in a special plate, or it was a tube in the very beginning, but now we use plates, petri dishes. And the second problem was the media. What we tried, or the scientists tried, to produce solutions which contains all the materials and the chemicals available in the normal human body, so we keep the same atmosphere. So there were lots of developments of this tissue culture media over the years, and still now there are more and more developments, and this was put into the conditions similar to the body conditions. So they were put in an incubator with a 37-degree and carbon dioxide, 5% carbon dioxide in oxygen in this media, and you wait and you take it out after 2 days to see how far is the progress, how many eggs was fertilized, and is it dividing properly or not. When we have the embryos, then we transfer the embryos through the cervix here by special castor and media, and we leave it into the uterine cavity to implant by itself. So instead of the natural pregnancy coming out from there, we are going to put it up there, and we replace the tube by the incubator and this procedure. And this is how the oocytes were collected by the eggs by the laparoscope. With the development of ultrasound equipments, it became much easier to give drugs and have a number of eggs become bigger, produced, and through the vagina, and this area of the fornix, it's very close to the peritoneum here, so by needle I can go into the peritoneal cavity very easily from here, into the ovary, which I see very easily by ultrasound, and I aspirate all these eggs by the needle without any opening, without any surgery, and in many countries it is done without anesthesia at all. Here, most of our women, they prefer to have light anesthesia, very light anesthesia. The procedure takes 10 minutes or so to be finished. If the problem is in the male, if I take the eggs outside and put the sperms, they will not fertilize because the sperms are poor or weak or very small. So we do what is called ICSI, or intracytoplasmic sperm injection. This is the egg. It is under an inverted phase microscope with a very huge magnification. And then there is a special pipette here, and there is a suction, very low grade of suction. So we fix this egg. All this is done under inverted phase microscope. The egg is fixed here, so it does not move. And then I come with a special, very fine needle, and I put the sperm in the needle from the beginning, in this needle, and I insert this needle inside the egg, inside the cytoplasm. I pierce this membrane, and I am here. And I inject one sperm inside the egg. And I wait for fertilization to occur and division, and fertilization is very successful. You can have about 60-70% fertilization rate, which is great because you will have many eggs, so you will have many embryos, and that was the first real success for treatment of the male infertility. That was developed in 1993. This is embryo division, different stages of embryo division. And some men, they do not have sperms at all coming out, but they have sperms inside the testicles. So we can take the sperms by needle, and we do the same procedure as we did with ICSI, intracytoplasmic sperm injection. Now, let us move to a step forwards. Pre-implantation genetic diagnosis. The idea is, when I do IVF now, or ICSI, usually I can get 15 embryos, and I transfer only few of them to, hoping that one will implant, or 3 maybe, or 1 embryo. The rest of the embryos I cryopreserve, I freeze in minus 270, I freeze it. They can survive forever. They can survive any number of years, and I can transfer them to the same woman later. Now, with this number of embryos I have, if a family is having a hereditary disease, a special disease which is carried on a special chromosome, and I know that this family is having this particular disease, then I can examine these embryos and see which are the embryos which are healthy, which are the embryos which is having this genetic disease. This is called pre-implantation genetic diagnosis. And it is indicated in familial chromosomal diseases, genetic diseases, carries on genes, and like, for example, thalassemia. This is a blood disease, very common in this area, Mediterranean area, very, very common problem in Egypt, which kills thousands of children in their infancy and young age, and it could be prevented by this procedure by transferring the embryo which does not carry the disease and the sex linked diseases. There are certain diseases which are present in certain families which occurs only to the males or only to the females. Then we look for the X and Y chromosome in the embryos and we transfer the right sex, the sex which will not carry the problem. So this family will not have a problem in the coming baby. As you see, this is an embryo now, not an egg or oocyte. This is already an embryo fertilized. There are divisions. These are different cells. So I fix the embryo and I insert something a little wider and I do suction from here. I suck one of the blastomeres, one of the cells, and I examine it by special technique for all the chromosomes, and the results usually takes few hours. Then I can know, and I do this procedure on all the embryos, next embryo, and those who are carrying the disease, they are discarded, and I only transfer the healthy embryos to the woman, so I prevent this disease. Now, very recently, in the last 2 years, there are developed techniques which can look for all chromosomes. Before, we used to look only for one, and we should know which one we are looking for, based on the history of the family, previous sister or brother, etc. Now, there are techniques which can look for all the chromosomes to see if there is any problem or not. However, this technique is still controversial. Is it really useful or not? How much it will increase? The cost is enormous using this technique. So till now it is not worldwide really, there is a big debate about it. The woman who does not have a uterus, there was no hope for her except surrogacy. Yani to have another woman to take the embryo which developed from the wife and the husband by IVF and take this embryo and put it in the uterus of another lady. Another lady does not have any genetic relation to the baby because the baby genetically is related to the father and the mother, and this woman will carry this baby 9 months, deliver the baby. Supposedly the parents will take the baby, but this created a lot of problems in the world and a lot of lawsuit cases because many of these women, they want to keep the baby and it is a problem. Anyway, this treatment is not allowed in Egypt, so this is not our problem, at least in this country. But the woman who does not have a uterus, now it is available a technique to do uterine transplantation. And this technique has been tried in animals for many years, mainly in Sweden, in Gothenburg. 4 years ago, I went to discuss as one of the discussants of PhD thesis on uterine transplantation in rats. The researcher there did uterine transplantation on rats, a large number, and it was successful. But in the human, it is much more difficult because surgically it's a very, very difficult technique. Plus that you have all the problems of transplantations like kidney transplantation, rejection by the body, heart transplantation. But the advantage that if we overcome the technical difficulties, this is easier than kidneys and liver, than all this, because you can use the uterus of any woman. A woman who is 60-year-old can donate her uterus to her daughter who has a problem. She doesn't need the uterus anymore. The uterus' only function is to carry baby. It has nothing to do with the femininity or nothing, only to carry babies. So, and it could be used very effectively in these young women. So you don't really need a donor who is going to lose one kidney or a part or a liver or anything, and you will have easily a donor from a relative, a mother or a sister or anything. So the problems of incompatibility, and you need to have very compatible blood groups and other groups will not be there. But there are 9 cases done, and all of them in Sweden, and they have several babies, and all the babies, of course, are pregnant by IVF, because whatever you do, you will not achieve the proper connection of the tube to the ovary. So these women, they do IVF, in vitro fertilization, straight away to become pregnant. And this is just how to do it, the technical, the connection, vascular connections, anatomical connections, etc., to do uterine transplantation. Now, this man, Bob Edwards, who is the late Bob Edwards, who died a couple of years ago, this man from the early 60s, he dreamt about doing in vitro fertilization and worked all his life. He was a professor of physiology in Cambridge University and dreamt all his life to sort out this problem, and worked on mice, worked on rabbits, in different forms of animals, and there were great difficulties. The first difficulty, how to take the eggs outside the body. But in animals, it is not difficult, because they can kill the animal. They can open the abdomen of the animal and then resuture the abdomen. It is much easier. How to have the exact time? You should measure certain hormones, and that was not available in the 60s. And then the culture media. Nobody knew exactly how to do special media and what are the components. All the hundreds of chemical components should be present in certain percentages to allow the egg to grow and to be fertilized. That was extremely difficult thing. So he spent all his life in his laboratory in Cambridge to make different types of media and to try this. And in the early 70s, he was introduced to this new instrument, which I described to you, the laparoscopy, new surgical procedure developed, where you can introduce into the abdomen something with good light without opening the abdomen of the patient, and the patient can go home the same day. So he went looking for somebody to help him to get eggs from women via this equipment, until he found a doctor in the countryside of England called Patrick Steptoe, and he accepted to try on infertile women, women who are very eager to get pregnant. So they started trying to time how to do this. He took the train for 2 hours every day with his media, prepared media in the laboratory, kept in a small incubator. That was in the 70s. Things were not developed until he went and Steptoe did the surgery, the laparoscopy, took the egg. Many times he retrieved nothing because the timing was wrong. And occasionally he retrieved an oocyte. He went back to Cambridge with the sperms and egg and trying to fertilize this. And after 4 years of experimentation in media, he could achieve fertilization in vitro in the human. He could. But now they want to put it in the uterus, and the woman should be pregnant. And in 76, they achieved the first pregnancy, but they were very unfortunate because the pregnancy occurred in the fallopian tube. They put it in the uterus, and the embryo went to the tube, and the tube ruptured, so there was no real continuation of pregnancy. In 1975, the whole TV stations all over the world, the whole American, British, Egyptian newspaper, the first page, everywhere in the whole world was the picture. This was a step. This is Bob Edwards, the scientist, and this is Patrick Steptoe in a press conference in London, where the whole world, the first news of the first world IVF baby, and this is the mother, and this is Louise Brown, the first IVF baby. We had very, very good relations with Bob Edwards, who liked Egypt very much, and he came twice a year. We invited him twice a year for our meeting conference to develop our laboratory in certain things, and he likes antiquities. Actually, that's one of the main reasons why he came to Egypt. And this is one of the pictures in one of the conferences. I don't know, I don't remember, was it in Egypt or somewhere in Europe? And the Nobel Prize Committee resisted very, very much to give him the Nobel Prize in medicine because of the ethical issues, because the Vatican was very much against the whole procedure and making strong pressure that any research in this direction should not have the Nobel Prize. But finally, he got the Nobel Prize, but unfortunately, he developed dementia and some sort of Alzheimer in the last couple of years, and he got the Nobel Prize 5 years ago, I think, 4 or 5 years ago in medicine. And at that time, his wife went and collected, and he didn't know that he had the Nobel Prize. The first baby was born in 1978 in the United Kingdom, and the first baby in USA was 81, and in France 82, and in Egypt, and by our groups 87, which is not bad, not very bad. 9 years later, the first baby from frozen embryos was born in Australia in 1981. The first baby from frozen embryos. Just few words about our group. Our group published over 200 publications in top international scientific journals, most of them with very high impact factor. We have a big research team. We participated in the development of this procedure, the technique, the media, the drugs, and everything, development of the procedure during the past 25 years. We had lots of prizes from different parts of the world. We are a big group of people. It is not a one-man show. This is a picture, I think, rather recent of our group, and this our part, and this our. We have biologists, around 15, I think, biologists, very well trained, and many senior biologists. We have 17 doctors and chemists, people who work in genetics to detect we have a very, very big team. It is a private center, but we allocate a certain percent to research, and we consider this as a very important and pride for every one of us. This is the IVF center. It's a 6th story. This is just part of the laboratory, one of the inverted phase microscopes where you do these injections. And this is just a book by Cambridge University Press. It's edited by me and one of my colleagues who is in America now. And there are 2 problems in the treatment of infertility which are not solved. Women with no eggs and men with no sperms at all. There is not eggs anywhere and no sperms anywhere. So far, the only treatment is donation abroad. Male sperm donation or egg donation, and in our part of the world this is not allowed. There are possible future prospects. Via stem cells, there are tens of serious publications in Nature and in Science on how to develop eggs and sperms in experimental animals, and still none of this is really successful. In animals there is a little progress in certain areas, but I think it is a long way to develop human eggs and human sperms, and thank you very much. تفضل يا
Dr. Aboulghar, thank you very much for this excellent presentation. This is considered the introduction to the lecture stem cells. Okay, you couldn't have a better lecture than this. And حتى أنا to solve an ethical dilemma for us. دلوقتي we have an issue with embryonic stem cells, is that you take the embryonic cell, which is the cell of the inner mass of the blastocyst, and that's considered killing an embryo, and therefore زي مثلا في أمريكا they stop the funding, national funding for stem cell research for a while during the Bush era. حضرتك mentioned a very interesting technique اللي هو pre-implantation genetic diagnosis, in which you take one cell from the inner mass of the embryo, and that does not destroy the embryo, right? Okay, so is this still considered an embryonic stem cell?
This is one cell of the embryo, but this is a very difficult and expensive technique to do to make stem cell line from embryonic cells. There are many embryos which we discard, which we don't use, and they have stem cells which could be used. The problem we have is the consent from the couple and the approval of the society and the authorities, that they will approve. I mean, this embryo for us and for the patient is useless, and we leave it so it degenerates in a few hours. There will be no embryo there. If I give you this embryo to do stem cell on it, I need approval of the couple, because this is not my ownership. It is the owner, although it is useless, but it is the ownership of the mother and the father of this embryo. And number 2, I need an approval of the authorities that I can give another institute these things. The first part, I think we can convince some reasonable patients to do it. But the second part, if you do it, we are going to provide you with what you want.
Thank you.
السلام عليكم، متشكرين جدا يا دكتور على المحاضرة الجميلة دي. أنا كنت بس بسأل مش عارف أنا ما فهمتش ولا لا، بس يعني هو في السكس ريليتد ديزيزز والفاميليال ديزيزز، يعني حضرتك قلت إن أنا بجيب الامبريو وبعمل اكستراكشن للسيل واحدة بس واحده بس؟
وافحصها. عندي 10 امبيو، اخد من كل امبيو 1 سيل افحصها اشوف لو لقيت الديزيز موجود في 1 سيل يبقى الامبيو ده كله يترمى ما ينفعنيش. وانقل بس الامبيوز اللي ما فيهاش
هو طب لو كده يعني هو مش في probability ان الديزيز ما يكونش في السيل اللي انا خدتها ويكون في السيل جوه؟
Chromosomes will these cells are originally coming from one cell. So originally this cell either is healthy or carrying the disease.
ماشي بشكل جيد.
علي صوتك عشان كنت سمعت حالة
طب حضرتك انا كنت سمعت حاله ان ممكن يكون الراجل سليم 100% وما عندوش اي عيوب، والانثى نفس الكلام سليمه 100% وما عندهاش اي عيوب، بس مع بعض ما يخلفوش، وفي نفس الوقت لو اتطلقوا والراجل اتجوز واحده ثانيه وهي اتجوزت واحد ثاني ممكن يخلفوا، ازاي كده؟
This is a condition known in medicine as unexplained infertility. There are some cases of infertility, women who cannot become pregnant, and there is no clear cause. The woman is normal, the man is normal. Usually, by in vitro fertilization, this couple can have achieved pregnancy. Usually. مش ضروري يتطلقوا ويتجوزوا تاني ولا حاجة.
سؤالي يا دكتور، IVF علاج فعال لسيدة بتعاني من كانسر في الرحم، وهل الرحم لازم يكون بحالة مثالية ولا ممكن في حالة وجود أمراض يكون الموضوع إيفكتيف؟ شكرا.
الكانسر بتاع يعني the cancer of the uterus، الكانسر بتاع الرحم عموما العلاج بتاعه بيتشال الرحم وبتاخد كمان علاج كيماوي في حالات كتير، فخلاص you cannot do anything، يعني مفيش الا لو زرعت لها رحم بقى بعد كده. وبعدين وانت بتعملي العلاج الكيماوي لازم تعملي طريقه to protect the ovary، لان العلاج الكيماوي بيموت الاوفري، بيموت الاجز، ف it is a big very big problem، يعني موضوع مش سهل يعني في طرق واخده بالك ان انا اشيل الاوفريز دي بره او اجزاء منها او اعمل لها فريزنج، وبعد ما العيانه تخف من اي كانسر بقى ان كان احط الاوفري الفروزن ده تاني. بس this is another subject بعيد خالص عن الموضوع ده، يعني this is another يعني infertility بعد الكانسر this is a huge issue يعني.
شكرا دكتور على البرزنتيشن الجميله ديت. عاوز اسال حضرتك، انت قلت لو الراجل مثلا هو المشكله ان احنا ما بنعرفش عليها ان لو ما يكونش سبيرم، طب هو ممكن يكون في راجل اصلا عنده سبيرمز بس كلها ميته يعني ولا هي مش موجوده؟
ممكن في حالات السبيرمز كلها تنزل ميته، بس الناس اللي السبيرمز بتنزل ميته لو خدت منه من التستيكل من الخصيه عينه غالبا بتلاقي حاجات صحيه قليله بس موجوده، حاجات موتايل سبيرمز ممكن تستخدمها.
هو دكتور بالنسبه للانفيترولايزيشن ده ممكن يحمي من فيوتشر ديزيز، مثلا فور اكزامبل لو عندنا فيوتشر ديزيز، لو عندنا مثلا فيري اوبيز وومن مثلا وده بينديكيت دايابيتس مثلا، فاحنا ممكن زي ما حضرتك قلت ذكرت ان احنا ناخد ايج وسبيرم ونعمل انفيترولايزيشن ونسيف ات اندر فيري لو تمبريتشر فور ايفر، فده هل ممكن يسيب فروم دايابيتس اللي ممكن يجي للمذر؟
لا يعني انت الموضوع ده مش كده،
لان انت لو انت عاوز تمنع ديزيز معينه هتدخل فان انت كله فيه دونيشنز، والممنوع انترناشونالي ليه؟ عشان هتبتدي عاوز عيل ابيض وشعره اصفر، وواحد عاوز مش عارف ايه، وعاوز هتلر جديد وعاوز كده. فعشان كده ethical there is no ethical approval in doing research in this area.
بس هو نفس الايج ونفس الومن.
اما خلاص الديزيز لو موجود هتمنع فيه ايه؟
يعني مثلا لو هي فيري بيس بس لسه ما عندهاش دايابيتس.
لا اصل ده جينيتك، ده حاجه موجوده على الجينز. لو حد هيجي له دايابيتس دي حاجه موجوده على الجينز.
مش هو ممكن الدايابيتس تبقى كوز باي الاوبيستي؟
لا، ما هو الدايابيتس نوعين. في نوع كومبليتلي جينيتيكالي اللي بيحصل في السن الصغير، وفي نوع بريدisposition. لو انت فضلت رفيع طول عمرك وبتاكل اكل معقول مش هيجيلك، انما انت نفسك لو تخنت هيجيلك. فاهم؟ ده من secondary factors. انما في جميع الاحوال مش هتعرف تحل مشكله بالاي في اف يعني.
اتفضل.
two questions. حضرتك كنت قلت ان انا بختار الاوسايتس عند certain stage. ايه stage اللي بختارها فيها؟
لا الاوسايت جوه المبيض. اجاوبك بالعربي بقى ولا بالانجليزي؟ ما اعرفش يكون احسن. يعني بيحصل فيها بتمر phases of development. اخر فيز فيها اسمها ميتا فيز 2 اللي هي بنسميها ماتيور ايج. فاحنا لو خدنا اي اوسايت قبل الستيج دي مش هنعرف نحقنها ولا نفرتلايز. انما لو هي قبل الستيج دي بحاجه بسيطه احاول اعمل لها ماتيوريشن ان فيترو، يعني اخليها تماتيور بسبيشال ميديا في الحضانه يوم او يومين توصل للماتيوريشن، وبعد كده احقنها.
السؤال الثاني كان برضه فكره بعمل يعني بوست فيرتلايزيشن، بعمل ميميكينج للميديا بتاعت الفلوبين تيوب عشان انهانس الجروث بتاع الامبريو. ده certain فاكتورز بتتحط في الميديا وهي ايه يعني؟
طبعا بصي الفالوبيان تيوب ميديا دي كانت في وقت من الاوقات كانوا بيعملوا زيها. دلوقتي ده سيرباسد الحكايه دي. هم دلوقتي الميديا كلها ارتفيشال ميديا، يعني كل شركه بتحاول تحط حاجات زياده وبتقول انها بتحسن الفيرتلايزيشن، بتقول بتعمل بيبر وبتقول وده بيقول وده بيقول. الموضوع يعني حاليا التوب كامبانيز الحقيقه كلهم ريزلتس كومباربل، يعني مفيش حاجه واضحه احسن من الثانيه.
ترايل ايرور يعني بيحددوا بالترايل ايرور بقى للميديا.
هم بيشتغلوا على انيمال امبريوز فور لونج بيريود قبل ما يبتدوا يستخدموا الهيومن يعني.
طيب ناخد اخر سؤالين. اخر ورا.
دلوقتي يا دكتور لو في ست الرحم بتاعها مش موجود اصلا، دلوقتي هل في possible way ان احنا نعمل artificial uterus بدل ما يبقى في donations من واحده؟
لا there is no way انك انت
so far. يعني انت حتى في الستيم سيلز انت بتعمل ستيم سيلز ما بتعملش اورجان. يعني انت لو عاوز تعمل ستيم سيلز لليفر للبرين للبون لاي حاجه انت بتعمل الكلام ده.
يعني مستحيل نخلي
لا بص ما فيش حاجه في الدنيا مستحيل اصلا. الكلام ده كله من 50 سنه لو حد قاله كانوا ضربوك بالنار وقالوا ان انت بتخرف. يمكن you never know، بس for the time being او in the near future it doesn't look like ان حاجه زي كده تحصل.
ان احنا نوفر الامبريو 9 months ميديا كافي 9 months ان هو
يعيش بره. بص احنا ابتدينا بالامبريو for 48 hours، واحنا على فكره بنشتغل اي في اف. السنه الجايه عندنا حفله كبيره وكل علماء العالم الاي في اف جايين مصر عشان هنحتفل ب 30 years of IVF in Egypt. 30 سنه في اطفال انابيب في مصر من 86. فلما ابتدينا كنا بنخلي الامبريو 48 hours، ما نقدرش اكتر من كده، خطر يعني البريجنسي هيقل. دلوقتي 5 days، يعني في 30 سنه بدل 2 days بقينا 5 days عشان تخليه 9 اشهر بقى. ربنا يسهل، يو نيفر نو. واخد بالك؟
اخر سؤال.
حضرتك يا دكتور دلوقتي المفروض ان احنا بتدي سبيشال دراجز للاوفري عشان تطلع اكس زياده، ده ما فيهوش خطر على الاوفري نفسها؟
لا ما فيهوش خطر على الاوفري، بس له سايد افكتس. يعني ممكن الاوفري ده انا عاوزه يطلع 10 راح مطلعني 50 مثلا، لان الست فيري سنسيتيف للدواء ده، فبطنها تتنفخ قوي وممكن تتعب، تقعد شهرين تعبانه، شهر تعبانه، تحصل فلويد كتير، اضطر اشفط وشغلانه يعني. ففي سايد افكتس طبعا من الدراجز، عشان كده لازم تدي دوز مظبوطه ولازم تعمل تيست مظبوطه قبل ما بتعملها.
حضرتك برضه كان على نفس النقطه بتاعت الارتفيشال الرحم الصناعي حضرتك يعني كان عمل قلب صناعي، فنفس الحكايه يعني قصدي الاجهزه الدقيقه او الاجهزه المعقده زي
ما هو اتعمل، لا ما اتعملش قلب صناعي. بص القلب الصناعي ده بيشتغل في عمليات الهارت سيرجري، بيضطروا يوقفوا القلب عشان يقدروا يشيلوا حته، يحطوا حاجه، يصلحوا فالف. لو وقفوا القلب المخ هيقف والدنيا هتموت. فعندهم هارت لانج ماشين، دي حاجه ارتفيشال، بيخلوا الدم بتاع الست او الراجل اللي بيعمل عمليه يطلع منها، يروح المكنه دي ويشتغل عشان الجسم الانسان يفضل بياخد كل حاجه عاديه لغايه ما هو يخلص العمليه ويوصل الحتت اللي موقفها والدنيا تمشي. مش هيمشي طول عمره بالهارت لانج ماشين. ده القلب الصناعي ده ساعه، نص ساعه، اللي هو لغايه ما بس يقفل القلب ويخلص العمليه.
انا قصدي حضرتك دلوقتي المشكله دي المشكله التطبيق موجوده عندنا تمنعها كعلم نفسه الموضوع ممكن.
لا ما هو انت لازم تديفلوب جوينت تيشو، لازم تعمل قلب هارت صناعي وقلب صناعي وكلى صناعيه، ودي لغايه دلوقتي نون ديفلوب. انت بتعمل سيلز بس بالستيم سيل، الحاجات اللي حصل فيها شويه تقدم في بعض النيورال سيلز وبعض البون سيلز اللي بيتحقنوا او ممكن تستفيد منهم السيلز، مش تيشو يعني، مش تركب لواحد قلب جديد ولا كلى جديده ولا بتاع. العفو.
بشكر شكرا جزيلا استاذنا الكريم دكتور محمد أبوالغار.
شكرا.
نتقبل الحاج دكتور صلاح وبيا نائب رئيس المدينه الشؤون الاكاديميه في هديه تذكاريه كده ودرع المدينه. عاوز
شكرا ميرسي خالص.
تقديرا يعني على تشريفك.
لا شكرا. متشكرين يا فندم. شكرا ميرسي خالص.
شكرا جزيلا. بالتوفيق ان شاء الله ونشوفكم في لقاء قريب.